Friends and colleagues, it's indeed a great honor and privilege for me to be here today. And today, actually, the topic is where should we revascularize patients with stable angina and where to give medical treatment. So without further ado, let me start with a story. And this is the story of a 67-year-old female patient who had chronic stable angina and her ejection fraction was normal. She was hypertensive and diabetic. And this is how our angiogram looked. And you can appreciate that there's some disease in the LAD as well as some disease in the LCX. However, we were unsure about the significance of these lesions, whether they were really physiologically significant. So we did an FFR, and first we did the FFR of the LCX, and even with maximum hyperemia, it turned out negative. We then proceeded to do FFR of the LAD, and that was also negative. So we counseled our patient, did intensive lifestyle modification advice, optimized her diabetic treatment, and she is doing just fine on medical management, and it's been quite a while. So indeed, many angiographically significant lesions are not necessarily physiologically significant, and stenting these lesions could result in overtreatment and worsened outcomes. And as has been alluded, FFR can really help us bring clarity to situations like left main disease, multivessel PCI, where we are unsure of which vessels to address, diffuse disease, tandem lesions, etc. Now this next case, this is a 64-year-old male who came to us again with chronic stable angina, 59% ejection fraction, hypertensive diabetes. Now you can appreciate that he has a lesion in the LAD, 70 to 80%, pretty long tandem lesion. The RCA looks definitely significant. It has like a 95% stenosis in its proximal segment. So for the RCA, we definitely decided this large dominant RCA requires treatment. We stented the vessel, did post-dilatation, and the OCT showed that the result was spot on. We then wanted to have an idea about the LAD, and the LAD we did FFR, and with maximum hyperemia, it came that the test was positive. This was indeed physiologically significant. So we went about stenting this vessel after pre-dilatation, did post-dilatation, and the vessel looked fine, both angiographically as well as by OCT. So we do know from the FAME2 trial that when we treat a physiologically significant lesion, we indeed improve the prognosis of our patients. And that's what we should be treating, physiologically significant lesions. So the question obviously comes, why do we want to treat stable angina pectoris patients? Well, obviously we want to improve their symptoms and quality of life. No one wants to live with being limited by chest pain. They want to do something, but the chest pain comes and they can't do it. So we want to improve their quality of life. And that's a very, very important and worthwhile goal that we interventional cardiologists strive to fulfill. But the other important factor that we need to remember is that we also aspire to improve the prognosis of their patients. And that can be measured by hard endpoints like death, MI, etc. And so if we look back, step back and look at the history of treating patients with stable angina, what was there? In the 70s, as has already been told, we had medical treatment, but that medical treatment was not really that great, and we had CABG. And when you compare that medical treatment, which was not really very good, with CABG for patients with stable angina pectoris, with all the studies, VA study, European surgeon study, CAS, it came out that the CABG did better in patients who were having stable angina pectoris compared to medical treatment. But medical treatment, as we know, in the 70s was not that great. But these were very small studies. Now, what Professor Yusuf did, he combined and pooled the data of all these studies. And in that also, it was found that the patients did better with CABG. But if you did a subgroup analysis, what did you see? These results were more relevant to patients with three-vessel disease, with left main disease, with patients who had LV ejection fraction dysfunction. And indeed, the STITCH trial also showed us that at 10 years, patients with very poor ejection fraction, they got the survival benefit. So you have to choose your patient wisely as well. Patients with poor ejection fraction, but who will be surviving for 10 years to get that benefit. So the answer that you need to revascularize patients, and those patients, the sickest patients, will derive the most benefit from your intervention when you are treating stable angina pectoris. Now, this is a comparison between CABG and medical management. Now, in recent years, we've had quite a few trials comparing medical management to intervention, like the COURAGE, the BARI 2D trial, etc. So let's go very briefly through them. Now, the COURAGE trial really did stir up our interest, and it showed that PCI did not manage to give benefit to our patients with stable angina pectoris in the hard points like reducing death or reducing non-fatal myocardial infarction. But one thing, in the medical arm as well as in the PCI arm, the patients were really, really well managed. They had to stop smoking. They had to get their LDLs really down. They had to reduce their body weight. They had to have all the optimal medical management. So in real life, this usually does not happen. Also, another thing, let's look at the enrollment criteria of COURAGE. They screened 35,000 patients, and they enrolled only 6.4% of these patients. So it was a cherry picking, right? And also another thing is that 1 in 4 patients were asymptomatic. So they don't have any chest pain. Here you're striving to improve their quality of life as well. If you don't have any chest pain, how will you say that, yes, my chest pain is improved? I didn't have any chest pain to begin with anyway. And also, at that time of period, there were only 2.4% of drug-eluting stents were used. The rest in the intervention or PCI arm were bare metal stents. So that was also a disadvantage. And another thing is that we need to know that 1 in 3%, 33% of the patients crossed over to the intervention arm towards the end of the study. So all of this makes you think about COURAGE again. If we look at the BARI 2D trial, which was a trial in diabetic patients where the revascularization arm was both CABG as well as PCI, there also we did not see any benefit in the revascularization arm. And in here, the revascularization arm means both CABG as well as PCI. And you would expect that CABG would have done better. And so, as I said, in BARI 2D trial also the secondary and the primary endpoints were not met. So if you look at BARI 2D, why was that? Now, one thing is maybe that they really did a very good job of the drug and lifestyle modification, and maybe also that there was a natural progression of the disease which caused subsequent events in the intervention arm. But you also might ask, was there any selection bias? If we go to the latest trial, the Ishikamia trial, in the Ishikamia trial, we all know that the subjects were all had ischemia as evidenced by exercise tolerance test, and then they were subjected to CT angiography. Now, the CT angiography was done to exclude any left main disease, which was excluded from this study. Acute coronary syndromes were excluded from this study. So after they had excluded all of this, they subjected the patients either to revascularization after angiography or medical management. And this was a neutral study. This also did not show any benefit in the revascularization arm. So where will we get benefit for our stable angina patients by revascularizing? In order to benefit from revascularization, one of the following 2 features which were excluded from the Ishikamia trial need to be present. One is the patient has severe refractory angina that is really hampering his quality of life, and the other is severe left main disease regardless of angina. and also multivessel disease maybe. Now, one thing that we have to remember is that we all talk about guideline-directed medical therapy. Now, what is guideline-directed medical therapy? So for most patients, obviously, you give survival benefit by giving statins, by giving aspirin, and by giving lifestyle modification advice, etc. But when you go for symptom control, according to directed medical therapy, you add on drugs. You start with a nitrate, increase the dose, you give the patient ranolazine, you give the patient trimetazidine, you go on giving drugs. Now, obviously, multiple polytherapy, that itself is a problem. And this leads, and it builds up cost. So this leads to non-adherence to drugs. So am I over time? Please, I'm sorry, I thought it was 15 minutes. So you need to add on drugs, and this really builds up the problem and leads to non-adherence and leads to cost. Another thing, when we look at evidence-based medicine, is that evidence-based medicine is, of course, there. We believe that. But we are in ground zero, treating our patients, and not one size fits all. So when we are doing clinical medicine, we know that some patients will have good outcomes, some intermediate outcomes, and some patients are really sick. And these patients need our help. So we need to identify these patients, and we need to treat them. And these are the patients who are most ignored because they have been left out of all the studies that we have conducted. And that's why I love this article by Ajay Kirtane. And this is like, we have actually a CHIP fellow with us, right? So he should really allude to us how important CHIP is. These are patients who require revascularization, and surgery is not being done to them because of their multiple comorbidities. And on the other hand, no one's doing PCI because it's not in the guidelines or what. So we really need to address these CHIP patients who are suffering from stable angina, whose prognosis, by the way, we can definitely improve. And just to highlight that, let me go through, I had 3 cases, I'll just go through one. So this is a 55-year-old gentleman who had chronic stable angina, hypertensive, diabetic, chronic kidney disease, and he's been refused surgery because he has very high serum creatinine level. And this is his RCA. It's a very small caliber, diffusely diseased vessel. And this is his left side. You can appreciate the calcification. And there's a long diffuse LAD which is calcified from its proximal segment, and the LCX is also calcified. So we did rotablation of the LCX first with a 1.25 burr. After doing rotablation with a 1.25 burr, actually the patient started having chest pain. Now, normally when we contemplate doing double rota, LCX as well as LAD, we'd remove the wire and do the LAD. But here the patient was having such a lot of chest pain, we had no option but to do PCI of the LCX, because there was quite a bit of dissection also, which is usually unusual with the rota. So we went about doing stenting, but here, just for an educational tip, positioning of our stent was crucial. We needed to properly position it. Otherwise, if we did not position it properly, we would not be able to do rota of the LAD. And here, the ramus, you can see the ramus. This ramus acted as a guide to our positioning. So after positioning we went on to do rota of the LAD after deploying our stent, doing post-dilatation, and it was fine because our stent was properly positioned in the L6 with no struts adjusting into the left main. We did rota of the LAD, had a look with IVUS, quite a bit of calcium there, so we did aggressive pre-dilatation with the NC balloon, and preparing our lesion properly is crucial for success. We then deployed drug-eluting stent for mid-LAD as well as drug-eluting stent for the proximal. We did post-dilatation, final result looked fine. Now, 2 years down the road, he started having a bit of atypical chest pain, so we had a look again. Everything was spot on. And so we were doubtful whether this RCA was causing any problems. Did a FFR, it came out negative, and this patient has been doing fine since then. I had two more stories, but I'll cut here because I'm short of time. So in short, I would just like to say that yes, we need to revascularize patients who are high risk, like cleft main disease, who have poor ejection fraction, and these patients will give great outcome. Thank you.